The academic partner for this session is ITAS. Dr. Kanan Muhammad Mustafil Karim is a celebrated name in hematology in Bangladesh.
Hello. Hello. Am I audible, please? Hello.
Yes, Dr. Karim.
Yeah. I am sharing my slide. Can you see it? Hello. Slide is visible.
Yes, Dr. Karim, we can hear you.
Okay. Slide.
Please start. Over to you.
Slideshow mode. Okay.
Can you hear us, Doctor?
Yeah. Okay. Thank you. Good afternoon, and this is very specialized. I welcome all of you to my today's presentation on MRD in multiple myeloma. I at first thanks the esteemed group of peoples and the speakers of the world and join in this meeting. Though this is a MRD in multiple myeloma is very much complicated, and this MRD cone, third MRD cone, especially for the organizer who organized and invited me in this meeting, especially Dr. Joydeep, SCG Eco group, and I thank all people who working behind it and invited me for this presentation. I have no disclosure. My two disclosure about multiple MRD in multiple myeloma is what we think we know, what we truly know, and what we believe we do not know. What we do not know, we do not know. That's a lot. Really, there is a lack of knowledge regarding the MRD in multiple myeloma. Besides this, there is a good hematological platform in the discussion for the multiple myeloma. I want to being a clinician, I want to present this this in the following headlines. This is a review of MRD assessment techniques and practical insights, and role of imaging in MRD assessment, the role of MRD to guide therapy and patient management. First, the review of MRD assessment techniques and practical insight in multiple myeloma. You know, the multiple myeloma is a heterogeneous, very multiple features of disease biology inside and outside the bone marrow. So there are different techniques to determine the multiple myeloma, MRD of multiple myeloma. The following are the techniques, the mass spectrometry to determine the M protein in the serum, and the next generation flow cytometry to determine the atypical plasma cells in the peripheral blood and the bone marrow. Next generation sequencing of BDSG to determine the clonotypic cells in the peripheral blood and bone marrow. And the PET-CT scan to determine the active myeloma cells in the intra and extramedullary bone disease. We know the multiple myeloma involving the bone marrow, kidney, very much, and it is the main organ, target organ is skeletal and the kidney. Besides the so many these techniques, there is a different techniques reflects the different part of the disease. So in different techniques, there is a lot of discordance and disagreement, and there is sometimes, sometimes we see that immunofixations become positive, but MRD in next generation flow is negative. So this type of discordance can be accepted, and we can accept it because these techniques reflects the disease involvement in different parts of the body. So for the determination of MRD of multiple myeloma, if two techniques, suppose any to immunofixation or a flow, it is positive, this is this is highly aggressive, and this is not controlled, or any two technique if negative, then it is very much authentic to that yes, MRD is negative and this is in the CR. So this disagreement, and we should work, and whole world is working on to standardize the multiple myeloma MRD detection. And besides being these disagreements is there, so though there is using of next generation sequencing, also more using in the clinical trials nowadays in the whole world, and especially in the developed world. And NGS is very costly, and it is less used in clinical practice in the US and Europe. And also NGF, that is next generation flow, is more using in the clinical practice than less using in clinical trials. And if we see this GEM201 and 2 Amiano OS 65 study, this is after MRD detection, after induction, and also after autologous bone marrow transplantation, then after consolidation. Then by using measurement of the multiple myeloma monoclonal protein in the serum protein electrophoresis, and or by immune electrophoresis by mass spectrometry. And these immunofixation electrophoresis, mass spectrometry, and NGFs, these three tests in the parallelly, and you can see the progression-free survival according to the results of the three technique. Superior and inferior progression-free survival is they are according to the test result. This according if the MRD is negative and if the MRD is positive. And individual features, current methods to monitor MRD is regarding the sensitivity issue of this test. It is very much important which test is more sensitive, and which test is standardized, and regarding the sampling. So many factors depends on it. And you see that next generation flow and next generation sequencing, now both methods are highly effective to stratify the risk of multiple myeloma. If we that four color flow is less sensitive than the next generation flow, and here, in MRD detection, if this 10 to the power minus 4 is less important than 10 to the power 5 minus 5, and if the patient in 10 to the power minus 6, then patient is more is disease free and more safe and more can pass a more relapse-free life, and patient is disease is more stratified. So 10 to the minus 4 is less, and 10 to the 5 less, and what our target is 10 to the minus 6, which is more patient can relapse less in these cases. Besides this, their test and their regarding it is very important to sampling because in NGF a live sample is required, fresh sample is required, but in NGS it is you can use this fresh sample, also use the stored sample, and the regarding the live sample, it depend on the quality of the sampling. If the sample is diluted, then it is the result will be erroneous, and the result will be false. MRD negative will show in the diluted sample. Uh, so very important for the collection. You see in this cartoon, you see that if the dilution of the sample in after cortisol infusion, first 1 month, 3 month, during first 1 month or first 3 months, there is they showing that MRD is negative. So individual doctor clinician will be happy that MRD is negative, but sample was diluted. Here is 0% of you see that B cell precursors and nucleated red cells and mast cells. But in after 6 months, you see the MRD is becoming positive and the patient relapsing. So the sampling is very much important. A diluted sample may produce a erroneous results. So next, regarding the role of imaging in MRD assessment, you know, though we are doing the PET scan, judo PET scan, imaging MRD negative, that is PET scan MRD negative indicates that the disappearance of every area of increased stressor uptake observed at baseline or previous PET CT or decrease to less mediastinal blood pool SUB. So if decrease to less mediastinal blood pool SUB, it indicates the PET CT that this imaging MRD is negative. So with this, we use the PET CT, FDG PET CT for evaluation of metabolic response to therapy, and after induction, before autologous transplant, PET CT, you can start in the baseline. You can do PET CT, FDG PET CT scan in the baseline. Then you start the induction, and then after the induction, if the patient is a CR, before autologous transplant, you do PET CT, FDG PET CT, and after autologous transplant, you do FDG PET CT, and before maintenance, again the FDG PET CT. And here showing that 65 to 80% of the patient after first line treatment achieve a complete FDG suppression. And according to the FDG result, the negativity and positivity, the overall survival and progression-free survival is the negative persons are more superior progression-free survival and overall survival. And the ISMO and the International Myeloma Working Group both jointly said that the algorithm during the follow-up for response evaluation, the multiple myeloma, I have told that before start of maintenance, if you do the FDG PET scan, then if you get the negative result, then it is the less chance to recurrence of the disease. And if it is positive, then you continue the treatment and you do the FDG PET CT yearly. And sometimes the FDG PET CT scan, these FDG PET CT standardized by D-value scoring. According to D-value scoring, D-value depends, scoring depends on the FDG liver activity in the different location of the liver, and accordingly this scale for D-value scale 1, 3, this is FDG negative, and 4 and 5, it is FDG positive, that is PET CT scan positive multiple myeloma, which indicates. And on the FDG PET CT in complete metabolic response, it effect on progression-free survival and overall survival is shown in the cartoon, and progression-free survival and overall survival increased in the negative individuals and negative patients. And the patients sometimes the FDG PET CT scans, baseline FDG PET scan are maybe negative due to the absence of the enzymes which circulates the FDG stressor in the body. So at this time, FDG is not used, and in this time you can use 11 carbon choline and 11 carbon methionine, and these are most that cases if FDG is negative in the baseline, this type of case you can handle by using this type of without using FDG, you can use this 11 carbon choline and 11 carbon methionine and others so on. Besides this, what do the patient in the baseline negative? If the baseline FDG PET CT scan negative due to the lack of enzymes or lack of any false negative result, then we can do whole body MRI and diffusion weighted imaging for response of MRD evaluation for multiple myeloma. And you know the MRD, multiple myeloma, it is highly whole body MRI. It is highly sensitive to detect the focal and diffuse disease in all bone marrow areas. It is shown in these following trials. And there are so many trials ongoing to standardize the PET CT scan, whether it is a diffusion weighted imaging, MRI, MRD after autologous stem cell transplantation versus PET in prospective trials. And different trials are going on to standardize the PET CT scan to incorporate imaging MRD and bone marrow MRD after treatment design, MRD driven trials in the whole world. There are so many trials going on, and the results are yet to receive to standardize the PET CT scan, because we know that next generation flow and next generation sequencing is standardized. But PET CT scan also, we are doing it, but still not standardized, and so many trials is going on. And next, a few things, as I am clinician, the role of MRD to guide therapy. What the importance for the clinician and patient in the patient management. So minimal residual disease in multiple myeloma, there is three questions: why, when, and where. And if we discuss about why, you know, in case of CR, after treatment, when you do the test, when after induction, this is in the CR, you can send MRD, and you can also in the transplant settings, you do the MRD, and after transplant, during pre-maintenance, you can do the MRD, and transplant eligible case, transplant ineligible case, relapsed/refractory multiple myeloma, and high-risk disease, high-risk cytogenetic disease, you can do this MRD test, and MRD negative is clinically relevant in standard for these high-risk diseases. So MRD is one of the most relevant prognostic factor in multiple myeloma. We should take advantage of this information to improve patient management. So when to implement MRD in clinical practice? When bone marrow aspirate is collected to confirm complete remission, according to International Myeloma Working Group guidelines, you can send for MRD, and when the results of the MRD assessment could help with clinician decisions and to confirm the patient MRD status. And where to do, you know, in case of NG, next generation flow and next generation sequencing from bone marrow aspirates, you collect sample and send for this MRD test. And for extramedullary disease, that is extramedullary or paramedullary diseases, for this detection of MRD, you can do PET CT scan and accordingly. And how you to do the you should can do use see that so many trial is ongoing to in multiple myeloma for MRD treatment decision, and yet no prospective there at this time there is no prospective randomized data in which the information from MRD testing can incorporate for the decision of the treatment. Still, this trial result yet to come. So no prospective data, randomized data in which the information about the MRD testing. So should therapy change to deepen response? Current practice does not intensify therapy above what was previously planned in patients who have not achieved an optimal response. But there is so many trials going on that the patient started treatment with CTD and CRD, and the patient after treatment with CTD and CRD, you see that patient there is a partial remission, and if you intensify with CBD and versus observation, there is a trial is showing that CBD addition of the CBD is more better than the observation. Intensification here helping the patient if the adequate response not happened in your initial treatment. And besides this, you after induction you do the autologous transplant and you do the MRD testing, and patient are showing that VGPR more than VGPR and MRD persistent MRD positive result coming from next generation sequencing. Then this trial, these ORIGA trials, they started and they use a LAN versus LAN plus DARA. So this trial will answer after autologous transplantation, persistent MRD positive case in NGS can help or not help. This trial will answer in future. And can we de-escalate treatment? Patients sometimes are coming to you and telling that when we de-escalate the treatment, current practice is to treat until progression. But patient could stop treatment to avoid adverse events and the burden of chronic therapy. This is a Spanish trial. They shown that after 2 years of maintenance therapy, the MRD negative patient and MRD positive patients, they have started this trial, and they when the MRD become negative, one side they stop the treatment maintenance, and on the other side they continued the LAN-DEX maintenance for 3 years. And last ASH meeting they presented in ASH, and they showing that these after completion of the study they will show the result. And in the PERSUASE trial, you see patient on a maintenance with DARA and LAN who are MRD negative can discontinue DARA and continue LAN. And this is also ongoing trial because patient start maintenance with DARA and LAN and become MRD negative, and after MRD negative you discontinue DARA and continue LAN. What is and these two arm, what is the trial results? We have to wait to get the result. So should therapy change if the patient become MRD positive? The optimal timing of treating relapse diseases. Yes, there. In case of a relapse case in the ENDEAVOR study, you see that patient in biochemical relapse and clinical relapse. If you start treatment in the biochemical relapse, the overall survival and progression-free survival is very good than if you treat in the clinical relapse. So if you can catch the patient in the biochemical relapse, it is good to start treatment than the wait for the clinical relapse. And the remnant trial, you know that these patients who are MRD negative after induction are randomized to start treatment at the time of MRD relapse versus at the time of progressive disease according to International Myeloma Working Criteria. This remnant trial is still after relapse of the patient. If you start with the treatment DARA plus KD or DARA in the relapse or in the progressive disease, this trial will answer us the future in the relapse case, how you will handle the relapse case in multiple myeloma. So many ambiguity regarding MRD of the multiple myeloma, and besides this, so many techniques are coming, and in the Southeast Asia, remaining the Southeast Asia, we are trying our best to determine the disease in remission, clinical remission, biochemical remission, and the molecular remission, because it is very important, because MRD is a very important platform for multiple myeloma in hematological malignancy. So in conclusion, newer treatment for patients with multiple myeloma have led to unprecedented depth of response. According to new and more sensitive method to assess disease response had to be introduced. The prognostic value of MRD assessment has been broadly demonstrated. There is a lag in data for how to use MRD result to make treatment decision. Ongoing trials provide the data to incorporate MRD testing in clinical practice to adapt which treatment we will follow. So many clinical trials, we are hope for the best for this, the result of the clinical trials. Besides this, the prognostication, MRD is the most important and broadly demonstrated. And thank you for your kind attention. And I convey my heartfelt thanks to Dr. Joydeep, who is leading the Kolkata SCG ECO in Kolkata, and invite me in this extreme group of people and the very expert international speakers, and I am very much delighted to say few words to and thank you very much. Thank you for your patience hearing.
We could see that you are doing wonders in these resource constrained settings. Thank you so much for joining us today. Thank you.
Thank you.
I would request Dr. Joydeep to introduce our next speaker, Dr. Bhuvan Kishore.